drug hypersensitivity. And by the way, we use drug hypersensitivity and drug allergy alternatively, but we prefer the term of hypersensitivity because it indicates the underlying immune-mediated process. So when we evaluate a drug hypersensitivity reaction, so we have to determine we have to tackle three major points, and that main points will help us to decide about the subsequent step in our evaluating our patient. First point is reaction phenotype. So when you evaluate a patient with drug hypersensitivity, we have to determine the reaction phenotype, and that what we will go and cover in subsequent slides. And then risk stratification. You have to determine stratify the risk for your patient reaction, either mild, moderate, or severe. This is important because this will help you to decide regarding subsequent step. And the subsequent step always in managing drug hypersensitivity should be guided by shared decision-making. So you have to discuss it with your patient. So when you determine, let's say, that your patient had a low risk, so it's clear that you will do immediately a challenge, not a skin test. But if your patient risk is moderate or high, then you may discuss the situation with your patient and see what is the patient preference regarding the doing a skin test for the moderate risk before the challenge, and also for the high risk with a negative skin test to do the challenge afterwards. So shared decision making is also important. So what subsequent steps you may take in managing the patient with drug hypersensitivity is either doing a drug challenge or drug skin test or drug desensitization, or you do for delayed reaction, delayed intradermal, which is considered a skin test or patch test, and this is specific for the delayed, in addition to other additional lab tests you may consider. So which one we should choose, like challenge, skin test, desensitization? This will depends, as I said, mainly on the risk stratification and also on the reaction phenotype. So you have to determine the phenotype to know where to go next. So what do we mean by reaction phenotype? We mean the reaction phenotype, it means the observable clinical characteristics associated with interactions from specific exposures. So it means the clinical characteristics or symptoms and signs the patient has. That's what we mean by the reaction phenotype. And reaction phenotype is gained, or we can get it or determine that by mainly starting by clinical history. And then this can be followed by physical exam in the acute case or an acute state. But let's say the patient came to you with a reaction that happened a few months back. Then the main tool that would help you to determine the reaction phenotype is clinical history, which is a very important source of information. So what do I need to get when I evaluate my patient with a drug allergy or hypersensitivity? I need to classify the reaction or the drug hypersensitivity reaction based on multiple points: the chronology, the mechanism. Chronology, we mean either immediate or delayed. So before we say it is immediate or delayed, we have to determine the latency period. So what do we mean by latency period? It is the time lapsed, or the time period since the first exposure to medication till the first dose the patient has taken to the immediate, like the initial signs or symptoms of allergic reaction. So this is the latency period. So in the immediate reaction, the latency period is typically within 1 hour, and it could be up to 6 hours or less. So more than 6 hours, it is not, based on the guidelines, it is not considered immediate. Non-immediate reaction is typically days or weeks, and it could be also hours after the exposure, typically more than 6 hours, but it could also start later, and we'll see in the next slides. And then I have to determine the mechanism or the endotype. So what do you mean by the mechanism? So what is the immune mechanism underlying this reaction phenotype or these signs and symptoms the patient has? Is it an IgE-mediated reaction? Is it an IgE-mediated reaction? An example of that is MRGPRX2 receptor stimulation and via multiple medications, including vancomycin, neuromuscular blocking agents, and fluoroquinolones. Or it could be also it could be T-cell mediated. In addition to many mechanisms we'll cover in the next few slides. And the third important part I need also to determine from the assessment of my patient is phenotype, as we mentioned previously. So what do we mean by how many phenotypes we have in the drug reaction? So the phenotype will help me to determine the underlying mechanism or the underlying endotype. This could be helpful. So if the patient had urticaria, angioedema, bronchospasm, or in severe cases anaphylaxis, this is for sure an immediate kind of reaction or that fits a possible IgE-mediated reaction, either IgE-mediated or non-IgE-mediated, but it fits with an immediate kind of reaction. Then non-immediate reaction, which means the delayed reactions, it can be divided either to benign exanthems like morbilliform drug eruption, maculopapular exanthems. So these are benign non-immediate reaction. Or it could be severe. So if the patient had any manifestation of DRESS or AGIP or Steven Johnson or TEN, this fits delayed reaction, but severe one, not a benign one. So severe cutaneous allergic reaction. But if the patient had only maculopapular eruption, morbilliform eruption, this goes with delayed reaction and also most likely a T-cell mediated benign reaction. So we have the chronology, immediate delay, the mechanisms, and the phenotype. And then I should then determine what kind of reaction the patient has. Based on the classification of the international consensus for drug allergy, the immediate type and non-immediate type is the main classification based on the chronology, as we mentioned. And as I said, the reaction phenotype can help you to know which one of these reactions you are dealing with. I would advise you to go over this paper. It's good, actually, a paper that covers the cutaneous manifestations of the drug hypersensitivity. And those cutaneous manifestations can be either immediate or could be delayed. We know that some drug reactions also have systemic manifestation, but this paper will concentrate mainly on the cutaneous manifestation. Now, how can we differentiate between these reactions? So, as we can look at this paper, in this paper they try to divide the manifestation, the reaction, or try to phenotype the reaction based on the try to phenotype the reaction based on the manifestations that the patient has. Or they try to classify the reaction the patient has based on the phenotype. So what do I mean when I say this patient has Steven Johnson or has 10? So what I'm telling you now is the phenotype. So the phenotype of the reaction is Steven Johnson 10. I mean, this patient is showing me signs and symptoms of Steven Johnson and 10. Is it necessary that the underlying mechanism shows this phenotype? It is not necessary. So that's what we mean by the phenotype that we can see. So in urticaria, angioedema, or anaphylaxis, this is the phenotype that we have. So let's say I'm trying to tell you this patient had a drug reaction with urticaria, angioedema, and anaphylaxis. So this is the phenotype. Can I tell you this is an IgE-mediated reaction? No, I cannot tell you because this is an underlying mechanism. I'm not sure about it. But what I can tell you for sure from the history and examination, what phenotype the patient has. So this kind of phenotype typically happen within 1 hour. So it is usually immediate. And there is a specific culprits, common culprits of such reaction like penicillin, cephalosporin, and NSAIDs. So How common the drug can cause it? It's common, but also you have to keep in mind that spontaneous urticaria, angioedema, and anaphylaxis, idiopathic anaphylaxis, can happen as well. So you have to be careful when you assess such patients. Stephen Johnson and 10, they for days to 8 days after starting the medication. Common culprits are mentioned here, including allopurinol, nevirapine, antibacterial, sulfonamides. So, but Stephen Johnson and 10 mostly is drug-induced. We cannot determine other differential when we see it. So it's commonly drug-induced. AGIP, which is acute generalized exanthemus pustulosis, and I will show you a few pictures regarding this. It is usually starting 1 to 12 days after the medication initiation. The common culprits are beta-lactam antibiotics, macrolides, and diltiazem, one of the common culprits. A vast majority of AGIP, again, is drug-induced. It's not common to be caused by different entity or a different cause. Vasculitis usually latency period is 7 to 21 days after starting the medication. Common culprits are beta-lactams, antibiotics, NSAIDs, and antibacterial sulfonamides, and it could be drug-induced, but also keep in mind when you see a vasculitis in your patient that differential diagnoses are there. Then DRESS usual latency period is 2 to 8 weeks, and we know that DRESS is drug reaction with eosinophilia and systemic symptoms, and this is a specific entity or phenotype of the severe delayed reactions, and usual latency period is 2 to 8 weeks after starting the dose. Common with certain antiepileptics, which is aromatic antiepileptics usually, allopurinol, dapsone, and some antibacterials like sulfonamides. Again, vast majority are drug-induced, so you can also get it secondary to a viral infection. And if we can get time for subsequent sessions, we may explain how viral infection can be a cause of stress, and this could happen. So, and I will show you the diagnostic criteria for DRIS, and one of those criteria is depending mainly on ruling out other causative infectious agent. So yes, infection can cause DRIS, not necessarily only medication. Then drive, which is symmetrical drug reaction with intratragenous flexural exanthema. And again, I will show you a picture of this. It is a benign kind of delayed drug reactions. And this is a kind of benign reaction that has a latency period up to 7 days. Usual culprits, very common culprits, are beta-lactam antibiotics, and it is, again, vast majority is drug-induced. Then macropapillary eruptions that can happen late, 4 to 14 days after starting the dose. Common culprits, antibiotics, antiepileptics, allopurinol, NSAIDs, all are common culprits. But keep in mind, macropapillary exanthem can be caused by other infectious infectious causes, especially in pediatric population. Fixed drug eruption, and this kind of reaction is an oval-shaped, purplish colored, may be covered by rough surface that happens in the same place each time the patient is exposed to the medication and recurs each time the patient is exposed to the medication. Usual latency period is 30 minutes to 8 hours after the administration, and common culprits including NSAIDs, very common, antibacterial, in addition to other agents. The vast majority are drug-induced again. And you have also to keep in mind a kind of, or a phenotype of reaction that we call it systemic photoallergic reaction that also can occur on the sun-exposed areas of the skin that happen after drug intake by days or even years. Common with NSAIDs, promethazine, chlorpromazine, and it is mostly drug-induced. I will maybe also go over how to differentiate between these phenotypes other than the interval, the latency period, which is mainly how do you look at those lesions and differentiate them. So this is the difference between the different phenotype, the different latency periods in the different phenotypes, as we mentioned. So this could also help you when you take the history from your patient to determine, based on the onset, in addition to the manifestations, which phenotype the patient has. So what next? Other than the chronology, is it immediate? Is it delayed? Other than the phenotype, the endotype, which is the underlying mechanism. This is important to understand, and this is also an evolving area in the drug allergy um, 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 involving area in the drug allergy research. So what do you mean by endotype again, which is the underlying mechanism? For the immediate reactions, we have different mechanisms. The major one is mast cell basophil mediator degranulation, and it is mainly IgE antigen mechanism. So the antigen will attach to the Fc epsilon receptor 1 on the mast cell or basophil and activate, cause the cross-linking and activation and release of mediators. This is the typical pathway we know. And additionally, there is non-IgE mechanism in which MRGPRX2, which is a receptor on the mast cells, can be directly activated, or maybe a direct membrane effect. This is one mechanism. Or IgG antigen interaction, and this will result also in an immediate kind of reaction. Or COX-1 antagonism that we see commonly with NSAIDs. Or maybe you can see ACE inhibitors reaction also that can present with angioedema. This is one kind of reaction we may see. Then cytokine and these mechanisms or endotypes will result in a specific phenotype, which is mainly typical immediate reaction symptom, which is nasoocular symptoms, cardiovascular compromise, decreased blood pressure, increased heart rate, lower airway compromise, hypoxia, wheezing, bronchoconstriction, gastrointestinal symptoms, vomiting, cramping, diarrhea, cutaneous manifestation, flushing, pruritus, urticaria, angioedema. In cytokine release related, it is not mediated by via IgE or MRGPRX2. No, it is mediated by T cell, monocytes, or macrophages, and will end up in multiple cytokine release. I will show you again in the subsequent slide. But what phenotype will result out of this is constitutional symptoms like fever, chills, rigorous headache, or cardiovascular compromise like tachycardia, hypertension, hypotension, musculoskeletal, truncal, and extremity pain. So this is extremely helpful when you assess your patient. So you see what manifestation my patient is having, and then I would know what could be the underlying mechanism or endotype. Then, mixed endotype owing to mast cell mediator and cytokine release, yes, this could happen also at the same time, and this will result in a mixed constellation of features mentioned above. And this is another good paper. I recommend again to look at it. That is mentioning the endotypes in immune-mediated drug reaction. So they explain the mechanisms that we may see. Now I would give you the summary of what I have said just a few minutes now. The endotypes and the immediate reaction. The first one is IgE mediated immediate drug hypersensitivity reaction, which is through mast cells and basophils. So what happens is the drug represented here by this red particle that will come and attach to the IgE receptor and cause, which is drug-specific IgE in a patient sensitized already to the drug, and cause the cross linking with another IgE receptor, and this with activation markers that we can see on the mast cells and basophils. You can see them here. So mast cells are activated, and then the end up is leukotrienes, prostaglandins, histamine, tryptase. These are the mediators released. In IgG-mediated immediate reaction, you have again mast cells and basophil stimulation, but it's not via IgE. No, it's via IgG receptor and by activating naive macrophages, and also in contribution of other granulocytes like neutrophils, and the attachment of the drug on the IgG. It's the FC lambda receptor, which is the low affinity receptor, but this could happen through the activation of other granulocytes and release, including neutrophil, and release of platelet activating factor and acetyl histamine and neutrophil extracellular traps and elastase. These are the mediators that are released in case of IgG-mediated reaction. And those could be helpful in measuring those mediators if we want to determine what endotype we have. Then MRGPRX2 mediated reaction, which is mass receptor, mass related G protein coupled receptor X2. This is the abbreviation of that receptor. So this receptor is on mast cells, and the kind of reaction will occur usually in patients who had this receptor polymorphism. So specific polymorphisms in the MRGPRX2 receptor will make the patient prone to such kind of reactions. So what happened is the direct drug stimulation of that receptor, and then activation of the mast cell and release of mediators. Then the COX-1, you all know about it. I think it's well-known pathway, and it is again COX-1 inhibition in mast cells will increase the production of cystinoid leukotrienes, prostaglandins T2, and decrease prostaglandin E2 and other mediators, and this will result in the typical reactions we see with NSAIDs. Cytokine release reaction, as we mentioned before, it's via T cell, could be also activation of NK cells. Multiple immune cells could be involved, including CD4 or CD8. And the end result is the release of those commonly released mediators, cytokine release, interleukin 6, interleukin 1, interleukin 8, 10, interferon gamma, TNF alpha, and those could be useful again, measuring and determining what phenotype, what endotype or mechanism my patient with immediate reaction may have. So how can we differentiate? This is a common question. How can we differentiate clinically between patient with IgE-mediated reaction and non-IgE-mediated reaction, let's say MRGPRX2 mediated reaction, especially both clinically looks the same. So they have the same phenotype commonly, but the endotype is different. So these are few points that could be helpful to determine that this reaction most likely is MRGPRX2 mediated reaction. Drug naivety, which means my patient who reacted to the drug, this is his or her first time to be exposed to that medication. So drug naivety is helpful. So this is most likely non-IgE mediated. So my patient is not sensitized, doesn't have a drug-specific IgE. Second thing is high dose. High dose is very, very common with MRGPRX2 mediated reaction because it needs high levels of the drug in the blood to react. And this we can see typically with vancomycin-mediated reactions. If you give the patient the medication very quickly, so the peak plasma level can go very high quickly, this can result in what we call Redman syndrome or flushing of the skin. So this is due to the high dose the medication reached in the patient blood. Presence of comorbidity like chronic urticaria, this is very common predisposing comorbidity. Fast resolution of cutaneous symptoms, this is also suggestive of RGPRX2. If the patient has very quick resolution, doesn't need a specific treatment, and doesn't progress, and has a very quick resolution, this is commonly RGPRX2. Now we go to the delayed hypersensitivity endotypes. So we know that what phenotypes we have for the delayed reaction. We have benign, we have scar, and we have different scars. So what could be the endotypes underlying? So the endotypes are commonly the same for all phenotypes we have, with few differences I would mention. Now, the first thing the patient had to determine any kind, to develop any kind of immune-mediated reaction is the contact with the drug or exposure. So the patient had a drug, okay, and then the drug, this is one of the theories, by the way. I will show you other theories that can also explain the reaction. So this is one of the theories, that the patient had the drug, and then the drug goes into attached covalently to the patient, a patient blood-derived protein, let's say human serum albumin, hemoglobin, or whatever kind of protein the drug is bound to. And then you have a haptenated protein. So it's a protein with a drug as a hapten. So this is the first thing you have, which is antigenic signal. So this is a complete antigen. Now you have that goes to your antigen presenting cells, and then that is not enough alone. You need a second signal. This is the first signal, which is antigenic signal. Then you need a second signal, as we know from basic immunology, which is concomitant or co-stimulation. And co-stimulation usually happen when you have a concomitant pathogen infection. This is a common cofactor, or maybe other non-specific signals not fully understood that has to be present, that will represent a damage or danger assorted molecular pattern. So you have to have a danger signal to have this activation, and then the processing of the protein and presenting the protein on HLA or MHC on the antigen presenting cells to the naive T cell with the help of a pro-inflammatory cytokines. And then you have a pathogen specific, a mature or pathogen specific or drug specific T cell in the patient blood. Now your patient is immunized. So the patient is sensitized. That's what we call a sensitization. So the patient has sensitization, either had a drug specific B cell that will produce a drug specific immunoglobulins, either IgE, IgG, whatever the mechanism the patient may have. And then you have the patient had another contact with the same drug. So this what will happen, the patient will have an immediate immune-mediated reaction, the stimulation of the responsible cells, and then the phenotype or the reaction that the patient will develop. And again, if it is a delayed reaction, also the patient who had a memory T cell will have a T cell activation with the subsequent contact with the drug, and then develop kind of delayed reaction with different phenotypes the patient might develop, either Stevens-Johnson, DRESS, or exanthema, and and each one has its own risk for mortality. So example of this haptenation is penicillin, like bacterium sulfamethoxazole, and nevirapine. These are common examples. Dendritic cells, as we mentioned, activation by direct activation or microenvironment, and this also needs other cofactors. And this I will go over maybe in the next slide, but I will just mention it briefly for you, which is what we call here. We mentioned that the patient will present the protein on the HLA. So there is something we call allo reactivity, which means the patient is having affinity or high propensity to develop a reaction to the drug, or has a high affinity to the drug on HLA, and this will produce more pronounced T cell activation or immune response. And this also happen when the patient had a specific HLA. So the example of this is with a patient with HLA B5701 who's at risk to develop a reaction to abacavir. So this is alloreactivity or propensity to develop because of this HLA. In this case, there is no need for antigen presentation or danger signaling. So you don't need this danger signaling. You don't need co-stimulation. If the patient has this alloreactivity, the drug can directly attach to the HLA and stimulate T cell via multiple mechanisms. I will also mention it to you. So those mechanisms are mentioned, luckily are mentioned here, which is hapten mechanism that we explained here. Other mechanism for the delayed reaction is PI concept. And also another one is altered peptide repertoire, and then heterologous immune model. I will explain those also next. So briefly about the infection. This is an important cofactor in many drug reactions, especially the delayed reactions. So how can the presence of virus can predispose to the drug reaction or make the drug reaction more pronounced or more severe? So the virus might interact with a drug, may interact with a drug and cause drug metabolites or new antigens to be to present and to be presented by dendritic cells to the T cell. Or the virus might cause modulation of the drug uptake and presentation, again via dendritic cells or antigen presenting cells. Virus also can happen PI and altered peptide. So the three mechanisms that the drug can cause a delayed reaction can be more pronounced when the virus is there. Also, the virus might cause modulation of the immune stimulation by increasing the adhesion molecules and cytokines on the immune cells during the immune reaction. Also, the virus could cause late autoimmune sequelae when it presents, and this also can modify or make the phenotype of the drug reaction more pronounced, more complicated, or more severe. So what we know mainly is we have multiple phenotypes of the delayed drug reaction, as we mentioned. We have macropapillary eruption for the benign kind of reaction. We have also other benign reaction like fixed drug eruptions that we mentioned previously. And we have also the exanthemas, flexural exanthema, which is again a benign reaction. And then we have a delayed severe reaction or scars, and this will include all of these phenotypes mentioned here. So we mentioned that delayed reaction followed usually three major mechanisms, which are hapten, prohapten, PI concept, altered peptide. That is true. But again, each phenotype of those delayed reactions has a specific subclassification of the Gillen-Coombs classification that we know. So we know that Gillen-Coombs has type 1, 2, 3, and 4. But type 4 is also subclassified into type A, B, C, and D. And this is specific for each phenotype of those delayed reaction. What is the difference? The main difference is the type of the T cell activated. In the type 4A, the main T cell activated is T helper 1. And the T helper 1 cell key mediators are interferon gamma, TNF alpha, interleukin 18, and macrophages activation. While in type 4B, where the phenotype is DRIS or drug-induced hypersensitivity syndrome or drug-induced liver injury, usually mediated by T helper 2. And the key mediators are interleukin 4, 13, 5, and the cells activated are mainly eosinophil and mast cells. While in type 4C, with a phenotype of Stevens-Johnson or 10, mainly mediated by cytotoxic lymphocytes. And as we know, fast ligand is playing a major role in such reaction with skin necrosis and death. So again, mediators are very important, including granzymes, perforins, and granulysin, important for the cell damage or cell death. Finally, AGIP or acute generalized exanthemus pustulosis, which is type 4D, mediated mainly by interleukin 8 T cells. Main cells activated are neutrophils with common mediators of GM-CSF, 6L8, and interleukin 8. So, is it very simple like that? No, it is not like that, unfortunately. If you go over the underlying endotypes in the delayed reactions, you'll find it more complicated. And also you'll find that DRIS, for example, has multiple underlying endotypes based on which mechanism is there. But I can mention to you briefly here that A delayed drug hypersensitivity reaction, let's say benign one, is mainly mediated by T helper 1, CD8 cells that can produce interferon gamma, perforin, granzyme B, eutaxin are common mediators. And then with DRESS, it's mainly eosinophils, as we mentioned before, T helper 2. So I would just recommend at this level to stick to this classification that yes, mainly DRESS is T helper 2 mediated, and it could be again T helper 1, but this is mainly if you are interested, you can go over it in the literature. There is more details about this, but general education, like for general education, T helper 2 is mainly DRESS, and Stephen Johnson is mainly T helper 1 with a rule of cytotoxic T cells, and AGIP is mainly rule of neutrophils, and also other mediators like interleukin 8, interferon gamma, GM-CSF, and others. So again, we stress on that mechanism that you have to know for delayed reaction could be hapten, PI concept, or altered peptide. Now, what do you mean by that? Hapten, prohapten, I explained briefly about it. So the drug is a hapten, and it attached to the protein and and it is a full antigen that can be presented to the T cell by antigen presenting cells. And for the T cell, other T cell mediated mechanism is PI concept, which is direct interaction of the drug with the immune receptor. This immune receptor can be either T cell or it can be also HLA on the antigen presenting cell. So either way, the drug can do it. Altered peptide repertoire, it means the drug will alter the protein sequence or the repertoire at the antigen binding cleft on the HLA. And this will result in the increasing the affinity of the T cell and increase the subsequent severity of the subsequent reaction. I'll try to simplify that as much as I can. So this is the PI concept, which is non-covalent bond with the drug to the HLA receptor, or maybe to the T cell receptor as well. So this is the drug, can be attached to the HLA receptor or can be attached to the T cell receptor on the other hand. Altered peptide repertoire, as I discussed, that on the HLA, the drug will attach to the antigen binding cleft and change the peptide sequence here, and this will result in increased affinity. Non-covalent bond again happen in this kind of reaction. The covalent bond happen only with the hapten prohapten, as we discussed before. So what about PI mechanism, which is a common mechanism when you have your patient reacting to the drug the first time the patient is exposed to. So the most suitable mechanism or explanation of what is happening is the PI concept, because this patient is not sensitized before, doesn't have a drug-specific T cell. So how this patient might react? So PI mechanism could explain this. So what happened is started with pharmacology, what we call off-target binding. So this is unwanted effect. So what happened is the drug will attach to either T cell receptor or HLA. The drug binds to the receptor, one of them or both, and then PI stimulation, which is pharmacological interaction with the immune receptor. What we mean by PI mechanism. So PI stimulation occurs when both receptors, both cells interact and make a complex. Then what happened? This pharmacological effect will convert into immunological subsequences. So what happened? Transformation of the pharmacological signal into immune effect function with occurring in reactive T cells. And then you get a reactive T cells secondary to this complex formation. Change of the T cell receptor HLA structures happened. So that's what we call allo-like stimulation. So there is change in that complex or structure that increase the affinity and and make patient more likely to be reactive, not tolerant. So changing the protein structure, the immune receptors, HLA or T cell receptor, by drug binding that unleashes the power of alloreactivity. And the patient then will, the T cells will become reactive with cytotoxicity and interferon gamma release. Then the drug binding effect by increasing the TCR HLA affinity. So this is the alloreactivity, which means that the T cell became reactive to the self, what we call reactive to that antigen, which is the drug. So what we mean by alloreactivity, that the T cell became reactive rather than tolerant. And additional to that, we have this increased affinity of the HLA to the TCR and vice versa. So some drug binding PI can enhance the affinity of the TC receptor and HLA interaction, affecting cytokine production. And those cytokines include interleukin-4 in CD and interleukin-5 in CD4, or oligoclonal T cell expansion, either CD4 or CD8. So we try to simplify what we have said. So this is the T cell receptor, this is the HLA receptor. So what we have allosteric effect of the TCR receptor on TCR receptor, so the drug will attach to the TCR receptor, okay, and cause allostimulation or cause alloreactivity, modify the drug HLA complex, elicit an allo-like T cell activation with cytotoxicity. This is one result. And also increase affinity. This is another result. So when the drug attached to the receptor of the T cell receptor or HLA receptor, this will increase also the affinity of each receptor to the other and increase interleukin-5 production via CD4 and cause eosinophilia. This is one of the results. Direct drug recognition via T cell receptor also or binding of the TCR or HLA both together can also cause stimulation of the T cell and cause oligoclonality. Again, altered peptide mechanism is explained here that we explained before briefly, that the drug will attach to the antigen binding cleft in the HLA and cause change in the peptide sequence, and this will increase again the affinity. So how can we make that in brief? So we have what we know, Gill and Coombs classification. So we have antigen in type 1, IgE stimulation. Type 2, we have mainly antibodies, antigen antibody. Antibody against cells with destruction of the cells that we know. Type 3, which is immune complex mediated reaction. Type 4 with the 4 types that we explained already. Additionally, we have the PI concepts that we explained now. 25 to 75% of the time, what happen is increased affinity. Result from that PI action is increased affinity with interleukin-5 production and eosinophilia with a phenotype of maculopapular eruption, DRESS, or AGIP, or more than 95% of the time, allo-like stimulation with the cytotoxicity, TCR drug HLA cytotoxicity with interferon gamma production with the phenotype of GVHD-like, like in maculopapular eruption, DRESS, AGIP, Stevens-Johnson, or 10. And few times, or less than or about 10% of the time, another phenotype can result, like AGIP or CDR-IFE. Then the pseudo-allergy, which is mast cell stimulation via MRGPRX2, is that increase inhibition that increase bradykinin or cyclooxygenase or COX-1 mediated reactions. So what is the role of HLA? We know now, when we understood now that HLA played a major role in the response to the drug. The variability in the HLA the patient had will determine if this patient is prone to the reaction or not. And that is what we do now, joining or linking some medication reaction risk to a specific HLA alleles the patient might have. So abacavir is linked to 55701, and allopurinol Stevens-Johnson 10 is linked to B5801, and many others, with a variable negative, positive, predictive values that are there. So you have to know that in your population specifically before you consider this as a screening tool to know which patient is high risk. And in this table, they mentioned that specific populations are at risk or carrying that allele in different percentages, depends on the available studies. So again, we explained now the endotypes for immediate, the endotypes for delayed, and here is the explanation in brief regarding each one of the reactions. I would maybe go over details of the manifestations of each kind of phenotype. Let's say macropapillary eruption, what is usually looks like. So it is burning erythema. It is a kind of delayed hypersensitivity reaction that present with papules and or macules, or maybe commonly macules plus or minus papules. So when you examine your patient, you have to determine or know how to, let's say, describe what lesion the patient has. So you know that micropapillary eruption, it has to be typically distributed, whatever the distribution, but it has to be macules plus or minus papules. How about photoallergic reaction? The patient usually have erythema, which is not specifically macules or papules, but mainly erythema, and it is commonly burning, and there may be bullous formation, by the way, on some sun-exposed body areas, and this also could happen. How about AGIP or acute generalized eczematous pustulosis? The patient usually has fever and rapid progression of large batches of burning erythema. So the patients start to have an erythema and usually associated with fever. And then that erythema is covered by dozens of small pustules, pinpoint pustules, very small pustules, and we call them sterile pustules. They are not due to an infection or folliculitis, they are sterile. And the mortality in such phenotype is really low. How about Stevens-Johnson or 10? I think we all know how does Stevens-Johnson or 10 looks like, but it's mainly blisters and extensive skin detachment mediated by fast ligand, granzyme B, and granulysin. This is perforin. These are common. This is very common clinical presentation. How about a dress? Dress usually has multiple organ damage. It's not only skin limited. And the eruptions the patient has could be macular, maculopapular, but commonly are diffuse. They are not localized, they are diffuse. And the patient usually has fever, eosinophilia, and the patient might have viral reactivation. So you have to screen your patient for viral reactivation, like herpes viruses, including human herpes virus 6 or 7. Also, you may consider other viruses like EBV, human herpes, EBV, CMV reactivations. And viral-specific T cells may be involved in the disease. This is a very common association with the DRIS, and mortality of DRIS is about 10% and could be more if the reaction is severe. And also the DRIS is a spectrum of disease. It could be mild, could be moderate, could be severe as well. Drug-induced liver injury, it is a broad spectrum of clinical syndromes, and multiple medications can cause it. Okay. These are the main phenotypes. I wouldn't go just in an... Okay, let's go over anaphylaxis. Anaphylaxis, usually we know how does it look like, how it could happen, and those are the clinical manifestations. This entity is a abacavir hypersensitivity reaction that is looks similar to DRIS. Usually the patient has fever, cutaneous eruptions are very common manifestation, and the patient usually is prone and having HLA-B 5701, and screening for that HLA allele could help to prevent such reaction. Other phenotypes you have also to keep in mind: serum sickness-like reaction. that is type 3, based on Gillen-Coombs reaction. The patient has urticaria-like lesions that persist more than 24 hours, and erythema, multiforme-like lesions, and joint inflammation with fever. But serum sickness should be associated with nephrotoxicity and hypocomplementemia, which is not present in serum sickness-like. This kind of phenotype is common in pediatric population, maybe more than adults, and associated mainly with vaccines. Anti-serums are very common culprits. Organ-specific delayed drug reaction, which is what we mean by drug-induced cytopenias, liver injury, interstitial nephritis, vasculitis, and these are commonly following Gillen-Coombs classification too, which is antibody-mediated cell toxicity. So we go back to what we need when you evaluate a patient with drug hypersensitivity. We know that phenotype, it has to be determined, and now we know what is the clinical manifestations that help me to determine what phenotype I have. And then I know now how possibly I could determine the possible mechanisms when I see that my patient clinically, or the endotype when I see my patient clinically. Chronology, we know how to determine the chronology now based on history. Now, the drug causality. This is very important when you have a reaction with multiple drugs given at the same time. When you have multiple medication given at the same time, then you don't know which drug caused the reaction. And this is common with the delayed reaction. Because with the immediate reaction, this could be much easier because it is an immediate onset kind of reaction. But with the delayed, you can look back for the, like, let's say, few weeks, a few days back, and you can see multiple medications given at the same time. So you have to determine what is the causality of each drug. So what you can do to help you determine is timeline that you can draw that can outline all drugs taken at the time first symptoms of the reaction occur, and the evolution of symptoms alongside the history of initiation of specific drugs. I can show you a timeline that I have here that is really helpful when you see in a consultation, let's say, your patient. So this is a timeline drawn for a patient who had anti-TB medications given, and then the patient had a reaction. And then the patient had a reaction. So they write now in detail which day the patient had received what and what happened. All the details are written on this timeline. So this is very helpful when you assess your patient. Now we go back. We'll try to be quick for the time's sake. Okay, we don't have much time actually. Time is gone. So I'll try to go over, let's say, now I'll show you just few pictures, determining how can you differentiate between different phenotype. This one, I think we went already over it. Which is the different phenotypes of the delayed reactions. Maybe you can review it. And then this picture is showing you multiple phenotypes or multiple manifestations that fix a specific phenotype. By the way, phenotypes can overlap, endotypes can overlap. So drug allergy is not always straightforward, but we try to simplify this here. So this is urticaria. This is Steven Johnston or 10. This is fixed drug eruption. So you can see this is fixed drug eruption here, oval-shaped lesion, or say usually oval-shaped pinkish or purplish lesion. But what we have here is multiple fixed drug eruption with pustules. So this is a generalized or bulle. So this is what we call generalized bullous fixed drug eruption. And this is not a benign. Keep in mind, this is not a benign reaction. This is a severe kind of reaction. You have to be careful before you challenge your patient. This is Egypt, which is erythema covered by small pustules. This is vasculitis, and this is typical rash of DRIS. And usually DRIS is associated with, facial angioedema. This is SDRIFA, which is symmetrical drug flexural intratriginous drug eruption, which is symmetrical flexural exanthema, we can call it. So you have erythema at the flexural areas or the folds of the skin, and it is erythematous lesion, could be coalescent papules, but usually erythema, and it is, by the way, severely itchy. So you can determine this by the patient presentation. So this is a maculopapular eruption or mobiliform eruption. This is injection site reaction. You can see it clearly. So maybe I will end up with this. So when you have a suspicion of cutaneous drug hypersensitivity reaction, how can you differentiate it based on what you have in examination? So first of all, as we said, drug exposure timeline should be drawn. And then the clinical picture, you should look at it. So what kind of rash the patient has, what kind of manifestation the patient has. So you start with the rash. Is it disseminated or generalized? Is it generalized? Yes. Then is it with or angioedema? If it is with or angioedema, this is immediate kind of reaction. Is there any non-cutaneous involvement? So this is anaphylaxis. If it is only limited to the skin, this is only drug-induced angioedema or urticaria. If the regions are not wheals or angioedema, they are exanthems, diffuse exanthems. Then are these exanthems with blisters? If yes, so if the patient systemically well, the lesions are oval erythematous patches with a central bullae. If that is true, then this is a generalized bullous fixed drug eruption. If the patient generally is not well and has malaise, mucous membrane involved, confluent erythema with arcuate lesions, this is Steven Johnson 10. So Steven Johnson 10, usually the patient looks generally sick. If those lesions are with pustules, yes. So are the pustules widespread erythema, and is there the neutrophilia the patient has and fever? If yes, so this is AGIP, acute generalized exanthemus pustulosis. Does the patient has purpura? If it is palpable purpura, this is vasculitis. Now, if those lesions are macules, papules only, so this is flexural intratriginous erythema or SIDRIFE, specifically if it is in the flexural areas. If there is non-cutaneous organ involvement with those macules, papules, so this is most likely DRIS. So DRIS is not limited only to the skin. And if nothing from those that we mentioned is present, so this is maculopapular exanthem. If the rash is localized, then is it a variolaceous discoid erythema plus or minus blister? Yes, this is fixed eruption. Is it on the sun-exposed areas with diffuse erythema, scaling, or vesicles? Yes, this is photoallergic reaction. Is it at the drug exposure site or injection site with induration swelling? So this is injection site reaction. So these are the guiding manifestation to follow when you examine or you assess your patient. Now, this is very, very, very important when you assess a patient with delayed reaction. You have to assess if your patient has a danger signs. This will help you to determine if this reaction is benign or a severe kind of reaction. If the patient has intense facial involvement with facial edema, this is a danger sign. If the patient has a typical target lesion, this is a danger sign. Bullous lesions, dark, red erythema, deeply pigmented erythema, this is a danger sign commonly happening with DRIS. Extensive pustulosis, this is really concerning. Painful skin, if your patient is telling you my skin is burning, painful, it's not itchy, this is a danger sign. Mucosal involvement, we know. Fever, more than 38.5. Generalized lymphadenopathy, commonly with DRIS. Elevated liver enzymes, renal function abnormality, alteration in the cell counts like anemia, granulocytopenia, thrombocytopenia, neutrophilia, xenophilia, low complements that can happen with serum sickness, hepatitis, nephritis, pneumonitis. These are danger signs you have to make sure. I think taking history, I'll try to mention it also briefly, what you need to determine when you take a history from your patient. When does the reaction happen? let's say how many years back, how many months back. This is really helpful in risk stratification. Then, what manifestation you have at that time? What are the cutaneous manifestation you had? Then, do you have a systemic manifestation with it? This is very important. What associated symptoms you had at that time? And what kind of systemic manifestation? Was the reaction immediate or was it delayed? And is there any possible contributing factors? Have you had a viral infection at that time? Had you had the flu? Were you febrile? Is there any suspicion of photosensitivity and other cofactors you may look at? And also ask your patient if there is any abnormality in the labs, any fever documented. Do you have any edema, any burning in the skin, any other manifestation like arthralgia, myalgia, lymphadenopathy? So you have to have all these details collected. What kind of rash you had? Do you have photos? Show me. Do you have a medical evaluation written to you at that time? Show me. If I have any medical evaluation or records, I can go and review. This is a very good source of information. So these are very important. And then you list your suspicious drugs, and you have to ask your patient again what management you received at that time. What kind of medication you have received? Do you need to be admitted or you stay in emergency? Do you need an ICU admission? Do you need steroid? Do you need any, do you need epinephrine or other medication? Those, or let's say biologic or any kind of reaction that can give you a clue regarding what kind of reaction the patient had. Then the background allergic comorbidity is important to take, and family history as well. And as I mentioned, involvement of other organs is really, really important when you assess your patient. We mentioned about personal history, allergic diseases. The also important in your take drug history, allergy history, is there any previous exposure prior to that index reaction? So have you exposed to it previously before you had it again and react? This is very important. And then ask about any other exposures, any other drug allergies the patient might had from any other drug allergies, because other drug allergies is a risk factor for many drug allergies. And very important, especially when your patient is having immediate reaction, specifically urticaria and angioedema only, to ask, do you have a background chronic urticaria and angioedema? This could be just an flare of urticaria and angioedema, not a drug reaction. And this is common scenario. Do you have anaphylaxis without exposure to a drug? This is a very important question, because your patient might have just idiopathic anaphylaxis, has nothing to do with a drug exposure. Okay, so those are very, very important. I would just maybe mention it briefly. I wouldn't go details. Those what we call the diagnostic criteria for DRESS. You have to know Regis-Scar criteria. You can determine based on the criteria the patient had. Is it a probable, possible, negative, or definite diagnosis based on the total score? And then you have J-SCAR or Japanese group criteria that is different from DRESS and has different cut points from the total. So it determines the typical, atypical, or definite, typical, atypical, or maybe you consider the diagnosis based on the total. These are what we call causality assessment scores or causality assessment tools. Very important for the delayed reaction. We have this score, Naranjo score for DRESS. This is Naranjo score for DRESS, and it has multiple questions. You answer yes or no, and then you collect the points, and you determine that for each drug. You do it for each drug the patient has exposed. This is useful when you have DRESS in your patient who is exposed to multiple medication. You know which is the cause. Then you do this Naranjo causality assessment tool. You use it, and then you do it for each drug separately and determine the possibility of that drug. Is it possible, doubtful, probable, definite that this drug is the cause? And then you have the Alden algorithm, causality for epidermal necrolysis, algorithm of drug causality for epidermal necrolysis, useful for Stephen Johnson and 10. And this is a causality assessment tool. You can collect points based on those assessment domains, and then you assess based on the total score. Is it probable, possible, or unlikely, likely, or definite based on that? And these are the details of the Alden scoring system. You can look at it. Finally, PINFAST, a well-known tool, which is PINFAST clinical decision rule. This is important when you decide about what to do next, or the risk stratification, mainly for the penicillin allergy. And it is also well-known tool. You can go over it. And it is present in the medical. Recently, there is publications regarding CIFFAST for cephalosporins, not widely present, but we could use it in the future. So based on those tools, you can determine if the patient has low risk. Low risk is usually when your patient has remote reaction, like many years has gone since the reaction, especially more than 5 years, based on the PINFAST tool. Benign cutaneous signs, subjective symptoms only, high number of listed drug allergies in your patient, drugs that infrequently cause allergic reaction mentioned by the patient. Those are all going with low risk. I think if there is no time, I would stop here if you prefer. And I don't know what we can do next. Maybe I can send you the slides and we can maybe do, I don't know. I will just wait for your suggestions. Maybe another maybe session to complete what we have remaining. It's only a few remaining, not too much. Or we may cover like specific drugs. For the time's sake, I will just stop here, and I need your questions, please.
يعطيك العافية دكتورة، وممكن نرتب السيشن الثاني بإذن الله. إذا في أي أحد عنده سؤال دكتورة صفية.
It seems no topic is is loaded. I think my slides, so no one has question. Either you understand everything or you don't get anything. So please let me know if you have any questions. I think we left with diagnosis and management of the drug allergy. I think that's what we are left with. Maybe we can do it
إن شاء الله بإذن الله.
later.
خلاص، الظاهر
Yeah.
شكله ما حد عنده سؤال دكتورة، يعطيك العافية.
الله يعافيك، الله يعافيك.
شكرا لك.
العفو، بالتوفيق.